we're going to be hearing from a group of teams here around how things have been going for their individual collaborative, their individual collaboratives. So what we're going to be starting with here is with the EPI team. Fred from the EPI team has actually provided us with some slides as well as a bit of a verbal presentation. So we're going to hear from Fred, even though they're not here. He's not here right now. We're going to hear from Fred and his EPI team. So here comes Fred.
Hello, everyone. My name is Fred Ott. I'm the clinical supervisor at the Early Psychosis Intervention Program. This top collaborative storyboard will be a brief update of our progress at EPI so far. EPI provides services to individuals who are experiencing a primary psychotic disorder or early on in their illness. We provide service to clients in the Vancouver and Richmond area between the ages of 13 and 30 for up to 3 years. EPI is very recovery oriented and provides a biopsychosocial approach. Our team is diverse. We're made up of psychiatrists, nurses, case managers, occupational therapists, peer support workers, and administrative staff. We receive our referrals from a variety of sources, including inpatient hospitals, other mental health teams, other health professionals. Family doctors and individuals. We're located on the 3rd floor of 2750 East Hastings Street, Vancouver. This slide reviews the EPI name statement. And what we're trying to do at EPI is to become more consistent at using the EPI outcome tool and to ensure that hopefully by the spring, we're using this tool more consistently and ensure that all of the clients who have treatment-resistant schizophrenia or schizoaffective disorder will be identified and offered clozapine if appropriate. Since November of last year until January this year, we've been able to start 2 more clients on clozapine and 7 more clients on IM at EPI. We've also been trying to incorporate the top screen and management tool into our regular workflow, but that has not been always consistent due to workload and staffing levels. For next month, we're hoping to complete the top screen and manage tool for 2 clients. Continue to identify clients who would be appropriate for injectable medications or clozapine. The challenges we're finding at EPI are 1, finding physician time to complete the PANT, the top screen management tool, to regularly monitor vitals in the community. 3rd, to stay up to date with the EDSA cycle and to complete the cycles. And finally, the lack of nursing staff. At the moment, we are lacking nursing staff.
I'd like to wrap up this presentation by acknowledging some of the EPI staff that have been involved in the top initiative at EPI. And I would like to thank you all for your time.
Great, thank you, Fred, for that presentation and the whole EPI team for the work you're doing. Up next, we have the South team. Is there a representative from the South team who wants to give an update to the teams on your storyboard?
I think that's me. Good morning.
Hi, Nicole, thanks.
Hi, I'm Nicole. I'm the resource nurse here at South, and we have a few members on our team with us today, as well as some who will be joining us later. So Dr. Sun, Dr. Sang, Julie, Dia, Christine, Jen, and myself. Just a quick blurb on the clients we support. We have approximately 1,100 clients and a variety of programs. Next slide, please. And so the aim for the South team was to optimize the treatment of clients diagnosed with treatment-resistant schizophrenia, with the potential to improve our clients' quality of life and well-being, reduce time in hospital, and increase their ability to meaningfully engage in their community. I think after team discussion, and please correct me if I'm wrong, but we are trying to have at least one client start on clozapine in community. We still have not found a suitable candidate, but we are trying. Next slide, please. So originally with our 2 top physicians and our clinicians, we identified 8 clients who meet the criteria for treatment-resistant schizophrenia. 1 client was started on a depot. Care plans were updated. As of right now, we haven't been able to find anybody who's eligible for a clozapine start in community. Next slide, please. So these pictures are from staff at our office. So I appreciate the pictures. Thank you, Julie and Donna and the rest of the team. So we've completed a few PDSA cycles. We're wanting to increase the population of focus by 1 client through education. We have some potential candidates, but we need to actually look into it in more detail. And so the education piece included physician meeting. It included having Dia present to our team what TOP entailed. So that's the first piece. The second PDSA cycle that we did was we were hoping to add a person with lived experience to the working group. And then a third PDSA cycle was to optimize the treatment of psychosis for a specific client. Next slide, please. So some of the barriers we found when trying to optimize treatment in the community. First one is non-adherence to medication. So one of the clients was started on a depot, but has now since gone back to oral medications. And just in terms of clozapine, just trying to find clients who would be able to take clozapine on a regular basis every day. So trying to figure out which clients would be suitable for that piece. We did have another client who, because of the client's comorbidities, the doctor wanted the client linked up with a GP, but just finding a GP who also speaks the same language as the client has been a barrier. Another barrier we found is finding clients who would be willing or able to complete regular blood work. Another barrier, it's more the language piece and linking that up to a GP who ideally would speak the client's language. And then the client who was put on a depot, but then stopped taking the depot. Originally, he did decline family involvement. And after team discussion, it is really important to try and involve family. And I think he has since had family involvement. So those are some of the barriers we found more with clients. In terms of the team, we haven't been able as of yet to add a person with lived experience. We've also found that we have limited staff bandwidth. So I guess similar to what EPI has found, just for regular follow-up to ensure safe client care is provided, especially if a client is started on clozapine in community. Also, our clinicians haven't really had a time to complete comprehensive PONOS assessments on all of their clients. And we did chat yesterday. We met with Darwin, and we thought one of the other PDSA cycles we could try to implement was maybe looking at more motivational interviewing resources and having access to the MI resources for our staff, and also psychoeducation in terms of medications. But you know, that brings up the broader question, like who would look into this and what would this entail? So again, it kind of goes back to the bandwidth issue. Yeah, so we're just working on trying to find potential clients. We do have a few, but again, doing the SAM tool and HONUS and going from there. Next slide, please. So those are our next steps. Yeah, thank you.
Thanks so much, Nicole. And I should add that we will have some time at the end of all the presentations to kind of, so any team can ask each other questions about how they were dealing with certain challenges and barriers and how they found these things. So if you are having any questions that are coming up, just keep in mind we can have a bit of a discussion at the end. Thanks, Nicole. Okay, so up next is the Northeast Mental Health Team. Is there someone from Northeast who wants to present your storyboard?
Yeah, Philip, I'll start us off. And I think I'll kind of be jumping in at different spots. But for those of you who don't know me, my name is Monica Thwaites, and I'm the team lead at Northeast Mental Health. I am here with Winnie Yu, our clinical resource nurse, Dr. Danielle Chin, our physician lead, and Dr. Jackie Hui, another physician at our team. So we are a community mental health team that provides mental health care to adults living with moderate to severe mental illness and addictions. We have around 800 clients at the team, and the team comprises of rehab staff, so rec therapists, vocational worker, occupational therapists, as well as case managers who are both nursing and allied staff. We have a substance use counselor, physician, and admin staff. Next slide, please. So to review our context, baseline, and aim, which are the same from the last presentation, but in terms of context, we're comfortable continuing clozapine management and initiating long-acting injections in the community. And we've identified that we're efficient at initiating and identifying when a client would benefit from a long-acting depot. Our aim statement: Northeast Mental Health will provide the identification of clients with treatment-resistant psychosis and optimize antipsychotic medications, including access to depots or clozapine. In the case of clozapine, Northeast staff will become more comfortable with initiating in the community setting. In the past, this has been facilitated by hospital, AAC, or Venture. This will contribute to our clients' quality of life and well-being, reduce time in hospital, and increase their ability to meaningfully engage in their communities. Our improvement goals are to: 1, by December 31st, identify the number of clients who meet the criteria for treatment-resistant psychosis and have active symptoms affecting their functional abilities from the population of focus. So we have completed this, and we focused on the caseloads of the top committee members and went through each person and did the SAM tool. We have not yet brought it to the full team, as we want to wait until the SAM tool is on Paris. Number 2, if medication adherence is identified as a possible concern, 75% of these clients will be offered a depot antipsychotic by the end of June 2022. 3, if the client has failed 2 or more antipsychotic trials, 50% will be offered clozapine by the end of June 2022. 4, 100% of clients offered clozapine will receive psychoeducation. And in addition, the psychoeducation will be provided to the client's primary care physician to assist with monitoring of side effects. And then another aspect of this was helping clients access primary care if they were not linked to a family physician. From the population of focus who consent to a clozapine trial, 75% of these clients will initiate clozapine in the community by June 2022, given no contraindications. Next slide, please. So our drivers and changes, again, same as a few months ago. Our primary drivers are decision support, so using evidence-based guidelines and integrating into daily clinical practice. And so part of that would be incorporating the SAM into daily clinical practice as needed. And then our second primary driver is delivery system design. Teamwork and expanded scope of practice is implemented to support chronic care. And also an aspect of this is ensuring appropriate staffing levels to safely provide clozapine starts in the community. Next slide, please. So our progress. Out of the top committee members, we identified 4 clients that are eligible for community start. As well, we informally by email introduced the top team to other physicians to let them know if they had any clients who would qualify for a clozapine start in the community and let them know how to access support from us. Now we're going to go into Dr. Hui and Dr. Chin are going to talk about 2 clients each that we identified for community start. So I will, next slide, please, and I'll hand it over to Dr. Huey.
Okay, can anybody hear me?
Yes.
Yeah, okay. So for the 2 clients I have identified, unfortunately, neither of them have started on clozapine because of different reasons. The first client has failed a couple of antipsychotics and has very severe tardive dyskinesia on the Invega Sustenna she's on. But we have decided that this kind is not appropriate for an outpatient start for a variety of barriers because number one, she's an older adult who lives alone. Actually, just moved to the Ravensong team catchment area not very long ago. She has multiple comorbidities which make commuting to the Northeast team very difficult. For example, she's got chronic urinary and fecal incontinence. She's got cognitive impairment. And also, she's had a couple of accidents on the bus where she fell and broke her arm. So she's not very open to taking the bus every day to the team for vitals for that reason. So she would need daily witness ingestion of medication, and the daily vital part, we've not been able to actually figure out a way to support her to come to the team every day. So, you know, after discussing this case thoroughly, we've decided that she is either most appropriately started either as a venture admission or at the Ravensong team. The client herself is not terribly keen on the idea of venture just due to previous experience. So I'm inclining to just wait till she's transferred to Ravensong team first and request her be started there. Now, the second client is contemplating clozapine right now, although he's not committed to the idea yet. He's got a history of schizophrenia and substance abuse, and currently is taking Invega and olanzapine and continues to be quite symptomatic. So he was actually previously tried on clozapine very briefly when he was in the hospital, but at that time he was very drug addicted and therefore was not able to comply with the blood work and to outpatient follow-up. So now he's finished rehab. He's 2 years sober. His schizophrenia symptoms fluctuate, so therefore his interest in taking clozapine also fluctuates depending on how symptomatic he is at any given time. But we are on a continued discussion for the start, and he's been provided with educational materials on the drug itself to read over, and we'll be talking about it on an ongoing basis. So those are my 2 clients. And I'll hand it to Dr. Chin.
Yeah, the next two are mine. So client C, she's a 60-year-old lady with a history of schizophrenia. Been here for several years at our team. Multiple medication trials. She's been on Pimozide, olanzapine, loxapine, risperidone, Abilify, and even with all those, she still has auditory hallucinations and paranoid delusions. We've talked about clozapine like well before TOP, at least dating back to 2018, but she's been really hesitant about the blood work. Yeah, I've been offering it on and off until I ask about it, but always decline. I guess the one thing when we were talking about it as a group that I haven't considered yet is the point of service, the pinprick blood work. So I haven't brought that up with her. That might be an option for her. But in the meantime, we're just ongoing discussion about it. And then client D, he's a 35-year-old guy with schizoaffective disorder and cannabis use disorder. So he's been on multiple different medications as well. The Abilify IM, paliperidone IM, Haldol, paliperidone, and olanzapine oral. And he basically had been on clozapine before and it worked really well for him, but then he did well and came off. And so this time around, last September, he actually asked to be put back on it. So we restarted it with him. We titrated him back up and we were doing pretty well until January of this year when he decided again that he's going to come off and just basically stopped at cold turkey. So I think the difficulty we have here is, once we start somebody, getting them to continue on. And just like in the future, if he wants to be restarted on it, because this is not the first time that he's been reinitiated, he's done that in hospital as well, how we kind of talk about continuing on for a period of time so we don't have the start-stop business because it's a big commitment for him, but it's also a really big commitment for us. It took us, many different people on our team to be able to do that. Yeah, so that's where we are with these 4 clients. I'll pass it back to you, Monica.
Yeah, so awesome. And I think Winnie's going to be taking it over from here.
Yeah, so the lessons we learned, so we saw just our progress, and now we're talking about what we learned. So during this progress, we know that like this regular ongoing blood work that is a barrier for clients, especially life lab booking system could be a challenge for the clients as well nowadays. And also clozapine maintenance is tricky for clients and I think the clinical staff as well. And each client needs a different approach for the starting of the clozapine in community. Time, teamwork, and collaboration also important. Next. So for the next steps, our next steps, we decided to incorporating SAM tool into our workflow, continue with occurring bi-weekly meetings for the QI top work, continue to problem solving and reach out to colleagues for ideas and support, introduce top to other physicians in the team and continue to discuss workload strategies. And also now we're planning to do some HONOs. Next slide. So we're increasing the HONOs education. The team will have a team HONOs session, and then we'll have ongoing dedicated time for HONOs. Next one. So we have our team contacts. Monica and myself will be the team contacts for Northeast Mental Health team.
Great, thank you, Winnie and Monica and the whole team there. You guys are doing a fantastic job there. Great teamwork presenting that. Up next, we have the Strathcona team. I think you guys have an update for us as well.
Hi. Hello, can you hear me?
We can hear you.
Hi, we're Hasni Musa, psychiatrist in Strathcona team, and currently we're we are the team members here in the group in the room, kind of sharing our experience. So next slide, please.
Oh, here.
Oh, it's here.
I've got it
Sorry.
here.
So this patient actually, he's under my care. He's a 49-year-old male with treatment-resistant schizophrenia. And he had multiple relapses in the past, admissions to hospital to restart back on clozapine. When his psychosis is treated, then he's doing well, he's independent in the community, but when he decompensates, he can be paranoid, aggressive, and also received input from the forensic psychiatry team in the past. Now, this relapse was slightly different in a way that he collapsed in the community. So taken to hospital, and we worked with the neurology and cardiology team to make sure it is safe to restart back on clozapine. So we made sure that like the EEG was normal, the cardiac kind of team gave us a green light. And what we did differently this time is we had the skills now to start clozapine in the community. So previously we would have asked the hospital to keep him there, like after finishing the medical team, he would have been transferred into the psychiatry ward to do the clozapine titration. But this time we felt confident that we can do it in the community. So we worked with the kind of pharmacy to make sure that his clozapine will be titrated as per schedule, that the clozapine will be witnessed to make sure that he's taking it. We made sure that we have resources to do the monitoring in the community, so to have his vital signs like blood pressure, pulse rate checked kind of daily. And the mental health nurse had kindly also provided psychoeducation to the building to provide kind of information about what to look for during clozapine titration, who to contact if there is an emergency, the time frame required for him to go back to his baseline. So this case, actually, we felt kind of the skills, the knowledge we got, kind of putting our efforts together to put this patient back on clozapine in the community worked well, really. And in hospital, I would say he's currently in week 2 of the clozapine titration. And I would say previously he would have stayed at least 3 to 5 weeks in hospital to start back on clozapine, making sure things are like in place, having passes to test kind of the treatment. But now we've done it in his own home, in his own comfort, and everything actually done safely and comfortably so far. So this is kind of the case I wanted to share, and I'll hand over to my other colleagues really to discuss other issues. Thank you.
So yeah, an ongoing barrier for us has been identifying population of focus for the top collaborative. So despite this above individual that Dr. Musa just highlighted, we found that the majority of our clients are excluded from the POF criteria due to myriad reasons, including concurrent substance use, unstable housing or homelessness, or are already on clozapine or a depot injection. The more that we as a group and then brought it to our larger Strathcona team, shifted and expanded our focus to come up with some more tangible QI initiatives, such as initiating CBT for psychosis and also upskilling in terms of motivational interviewing. We realized there was more options we could do.
Yeah, so we're trying to find ways to support our team. Like Cara said, upskilling our team with CBT and motivational interviewing for psychosis. We're going to try to shift our top focus to this in hopes of kind of identifying further ways to optimize treatment for our specific population. So we're going to look into see if we can find some in-house training opportunities, which could also help kind of standardize our practice across our team through the case managers and physicians. Yeah, that's what we have.
Great, thanks so much, Strathcona team. Again, you guys are really seeing a lot of like teamwork, like the whole team kind of like stepping in together and working on solutions to the individual things that you guys are coming up with as teams, the individual challenges you're coming up with as teams. So great work, all of you. We're just going to take a little moment here to open up the floor to some questions and answers for teams, maybe to step in and ask any questions about any of the storyboards that you've heard so far, or any comments about some of the challenges and some of the ways that teams are, how are teams accepting those challenges and what are they doing to get across those barriers. Yeah, just wanted to open it up to the whole group to if there's any questions around that for teams.
Thank you, Philip. I was just going to comment on a couple of things there. Thank you, Northeast team, for thinking about some of the difficult clients that you have had. I know you're making a lot of effort to see what you can do from your end. A lot of times there are no quick solutions to this. Like in Dr. Mathis' presentation, sometimes we had to go way out of our way to do things in a new way, like starting dialysis in the community, for example. This is a very big challenge, the clozapine as well, because we don't have all the resources and we need to think outside the box. One thing that I was thinking was, do you have, or the Strathcona team, I think what I heard consistently from all the teams is there's a bit of a challenge to educate the clients, and they keep kind of saying no to it, or they decide yes, and then they go back, and then they come back saying, no, let's not do it, or they stop the clozapine midway. So I was just wondering whether any of the teams there has a kind of a formal way of psychoeducating, providing psychoeducation to our clients. Like, does a team there amongst us who kind of run groups for newly diagnosed patients with psychosis, or those who have been identified as having treatment-resistant schizophrenia? Because I know, like, we talk about motivational interviewing in our busy clinic. In the 30 minutes, if the client arrives 15 minutes late and we have some important things to do, it just ends up as like asking them, do you want to go on clozapine? It can give you myocarditis and a granulocytosis. Can be very challenging for the client and even for us in a lot of ways. So just wondering whether there's a team that runs a group that the occupational therapist runs or the physician runs. I was wondering, probably EPI had something like that, but just curious if other teams are also having anything like that. Would be nice to hear from you.
Maybe to reframe Harisha's question as well, for some of the teams that have presented that have done a clozapine start or are in the process of doing it right now, what have you guys found has been helpful for the client education piece for those ones that you're starting or have done a start for? Has there been something you found has been working well?
So one of the things this reminds me is of a childhood story that I heard of Christopher Columbus, right? So when he kind of discovered North America, he went back to Europe, and apparently he presented to a lot of audience his work. And someone said, like, what is so unique about you trying to find a new route to East India? You go the wrong way and you accidentally find this. And to that, his response was like, he apparently asked everyone to kind of make an egg stand straight. And a lot of people, no one could. And then he smashed the egg and made it stand. And they all said like, hey, that was very simple. We could have smashed that egg, make it stand. Why is this unique? And he said like, this is exactly what you didn't do, and I did it. So just thinking what you guys can come up with, any unique ideas, thoughts, suggestions would be nice. It's not an easy one, but I mean, just to think for ourselves.
We're going to start off with, or continue with, the next round of storyboard presentations. The first team that we have joining us for their presentation is the Kamloops team. They joined our collaborative just a month or so ago. They've been engaged in conversations with us for a few months to join, and we're excited to have them here so that we can learn from them, and they can learn from us, and we can share our knowledge. Christy, I'll hand it over to you.
Hi, everyone. I'm Christy Baker. I think I've met some of you, obviously mostly online. I am the nurse project lead for our Kamloops team. And yeah, so I was hired back in December to sort of project coordinate for our team for Carla Manti and Dr. Molgat. So you can move to the next slide and I'll introduce our team members there. So yeah, we have Dr. Carmen Molgat, who's a psychiatrist at Royal Inland Hospital and Hillside Center. So she's our physician team lead. Carla Manti is our director of clinical operations in MHSU in the Thompson region here. Ray Sampson is our manager at Kamloops Community Mental Health Services. Myself is the nurse project coordinator. And then we have Kyle Hepner, who's our physician QI consultant that was brought on to help Carmen with her physician QI project and then lead us in all the QI components of our project. And our focus group is Kamloops Community MHSU Services. So that's the clinicians, psychiatrists, and clients within that service in Kamloops. Next slide. So our context baseline and aim statement. So Dr. Molgat had the vision that she wants to aim to find out how clients can safely be started on clozapine in an outpatient setting here in Kamloops within IH and also within our Kamloops region. Right now, clients mostly go inpatient to start clozapine. So through this process in the last couple of months, our focus has really come down to that we want to identify and address the barriers to the utilization of clozapine treatment in clients with TRS and in assessing current psychiatrist and clinician confidence to start clients on clozapine in a community setting. Our aim is to increase that knowledge and confidence, with the development of evidence-based resources, pathways, and protocols to help support our clinicians, clients, and their families within Kamloops. And then, of course, the overall arching benefits are going to be to the clients, families, physicians, psychiatrists, clinicians, and of course, Interior Health as an organizational whole. And our population of focus is in line with the top, and that would be clients meeting criteria for treatment-resistant schizophrenia. And I don't think because we came on late, have never shared our initial aim statement from our project charter. So our aim statement is to develop the protocols, pathways, and resources necessary to support physicians and clinicians to offer a Kamloops MHSU client a community clozapine start by May 31st, 2022. So we haven't, in our reporting periods, we haven't started anybody on clozapine yet or sort of really nailed down what that identification of the clients will be. We're focused right now on developing what those guidelines and pathways and what that criteria will be for identifying those clients that will meet the criteria for a community start. So we really kind of took it on that we need to have all those things in place before we can move forward with offering for clients in later spring. And then we'd have all of that kind of baseline work for our community clinicians and psychiatrists. Next slide. So with our quality improvement clinician, Kyle, our primary drivers were identified as those pathways, protocols, and education resources. And then staff identification and engagement. So identifying which teams within our MHSU would be our focus for rolling out those education resources and providing the guidelines and pathways. So mostly right now we're kind of looking at our ACT teams and our treatment support and recovery teams within those Kamloops teams, and we build from there through those PDSA cycles. And then our secondary drivers are clinician and physician input, developing the pathways, protocols, and resources, and then providing that education for staff, clients, and I think we missed families there, but families. And then project education along the way, so making sure we're providing the updates from both the collaborative with you guys as well as how our work is going within our QI project itself. And then our change ideas and project work to date were Dr. Mogat and Carla's idea was to bring on me as the nurse project lead to sort of coordinate all of this work and work with our teams in Kamloops, obviously getting their feedback and engaging stakeholders, doing the environmental scan. And then we as a team developed a pre-survey to clinicians and psychiatrists to assess that baseline knowledge and confidence with clozapine, and then ongoing staff engagement, and then our planning for education sessions. And we have sat down as a team a couple of times now, and we're actually able to get 2 other community psychiatrists to participate, as well as a team lead for our ACT team in Kamloops, and then all of our team members to do a patient journey map. So I couldn't figure out how to attach it to here, but we will share it at some point, or I can figure out how to share the link from our QI consultant. But really we wanted to map out the steps of how a journey would look for starting our client on clozapine in the community, and then use that as a guide to what pathways we thought we needed, what guidelines we needed, where kind of lab work requisitions would fit in and that kind of stuff. So we mapped it out that way so it can guide our processes going forward. Next slide. This is just some of the data from, sorry, my dog's in here, which is not ideal. We mapped out our clinician pre-survey responses. So you can just see, this was the clinician pre-survey. So we talked about how they felt with the current available Kamloops resources, how confident they were to monitor clients on clozapine. So you can see those results there, that somewhat comfortable and very uncomfortable were sort of the more high ratings that came back. Obviously showing that there's some improvement in what resources we need to support that. And then we asked, do you consider there's a need for a standardized evidence-based clozapine program in Kamloops? And we got 100% response of yes there. Next slide. And then this was sort of to guide what we were saying about addressing the barriers that there currently are. So this question was, in your opinion, in the Kamloops community setting, what are the barriers to initiating and maintaining eligible patients with TRS on clozapine? So we kind of laid out some options, and they were able to choose and identify. And as you can see, the clinician knowledge and comfort in monitoring, as well as service coordination and lack of standardized protocols, were the high ones there. And then the lack of standardized resources. So as we said, we use this as a pre-survey so that hopefully when we do develop those resources and stuff, we can go back and ask them the questions again and reassess those answers. Next slide. And then we broke down the questions to physician as well. So we just kind of, I think mostly we reworded the first one because they would be the ones who are initiating that clozapine treatment, and So that question was just worded a little bit different to tailor to the positions that we asked in the survey. And so, so they were saying mostly somewhat uncomfortable they were with being able to initiate clozapine in a community setting currently. And then it was another 100% yes about thinking that we needed a clozapine program in Kamloops. Next slide. And then we asked the same question about what they felt the main barriers were to initiating and maintaining the client. So service coordination being the largest one there, administrative barriers for the patient registry, lack of standardized protocols, but kind of all over the map. But those ones kind of coming back as the main percentages there again. Next slide. And then, so we plan to take that information from the survey and go forward with our next steps. So we're gonna now start working with our professional practice offices and our director and look at what evidence-based resources we feel. I mean, obviously there's lots from our environmental scan that we can pull from, but we want to adapt them to our needs within community here. And then have those packages that we can have for physicians when they want to initiate, as well as for patients and families that we can hand out to them when we're gonna talk about starting somebody in the community. And then we plan to roll out education sessions. So I think there's actually some coming from top that we plan to roll out, and our initial plan is to start again sort of with our ACT team and our treatment and supportive recovery team as PDSA cycles, and then re-survey people and see how they felt about the education provided, and then roll that out further within our team. And then also develop the information support resources for clients and families. So we want to talk about patient handouts for them, pamphlets, and then group sessions that families and clients could attend on clozapine. Next. And then this is just our team contact information. So that just goes over the team members again. I'm going to be sort of the point person for the project, but I can always bring anything else forward to everybody else. And of course, everybody's emails are listed there. So if you have any questions for us or anything that you'd like to share, and we of course appreciate everything that's being shared with us, and we're taking all of that information in and utilizing it within our project. And I don't know if Carmen wants to add anything, but she's on.
Hi everybody. I'm glad to be here. It was an interesting day. I wasn't able to be part of the entire session, but definitely very, very good session. We're gonna make time to come to the next ones for sure. So Christy has outlined quite well what we have done so far. As you can see, we are quite early in the process. But I'm hoping now that with some engagement of the community team, we can develop the toolkits, so to speak. And I think that will be the challenge: how much or how little do we need to provide? And that's why we thought of engaging the teams quite early in the process. So I'm really hoping that we can do some test trials by the summer. But with the PQI project, most probably we're going to stop just before the trials. So yeah, that's where we are, and I'm happy to take any questions, and Christy as well. I think the big advantage here is that we have a relatively small community, and with staff that has been around for a long time, so that trust that was talked about in the morning already exists there. So it's at the level of clinicians, physicians, but also leadership, managers and directors. So yeah, very happy to work with this team. It's been great.
Thanks so much, Carmen and Christy. If anyone has any questions, feel free to type them in the chat, and I'm just going to move us along to the next team. Next up, we have the Assertive Community Treatment Team, ACT. I'll hand it over to the team.
Hi, this is Dr. Tayyebe Jukar, psychiatrist for ACT team, ACT 1 team. So this is our team. People who are involved in this top collaborative projects are Karen, the manager, myself, Charmaine, who is the clinical resource nurse, Marcia, and Alex, nurse and social worker, and also Joe, who joined us recently, who is an occupational therapist. We are in at VGH campus, just across the street from Vancouver General Hospital. If you have seen our office over there, we are 6 teams, Act 1 to 6. We take care of people in the community. Can you please move to next slide? So basically, ACT, as many of you guys are aware, is a client-centered, recovery-oriented mental health service. We facilitate community, we try to facilitate community living and providing psychosocial rehabilitation and also recovery for people who are who have the most serious mental illness, very complex mental condition, substance use, and at times medical issues, and they haven't been benefited from traditional mental health program, mainly because of lack of appropriate housing, lack of family supports, and they require lots of outreach and support by ACT team. Basically, ACT services are delivered by a group of multidisciplinary team who are working as a team to deliver mobile service in community locations. And we are mostly covering Vancouver, the whole Vancouver, but mostly most of our clients are located in downtown East Side. Our team has been going through multiple losses due to overdose during the last several years, which has been very traumatic to other clients and as well as the ACT team members. And we are, as I mentioned, we have lots of difficulties because of lack of appropriate housing, limited treatment beds across the acute or tertiary spectrum, and as well as low and limited addiction resources for our clients. Our aim as a team is to improve mental health condition for our clients, and in order to improve their quality of life. And the plan is, our aim is to decrease hospital admissions, improve their medication adherence, and improve their community integrations, as I mentioned, increasing their quality of life. And why it is important right now, because we believe we have appropriate resources to incorporate best practice and support this highly marginalized population. We have appropriate resources, but still we need more resources and support whatever is available. We are more than happy to help, to use them to support our clients. Can you please go to next slide? So the ideas that have been, changing idea is we have some challenges in order to recruiting staff to join us for these top collaborative projects. There are for different reasons: lack of time, different time, work schedules. But we have done, hard effort to recruit more people, engage more people from ACT team to provide effective top care. Recently, we have been able to identify population of focus, narrowed down to one client. We have basically multiple clients that could be fitted in this top project, but in order to make it easier and workable and practical, we just want to use one client per team to benefit from this treatment optimization, not necessarily connection with clozapine. Some of our clients are already on clozapine, are on second generation or first generation antipsychotic injection. So we try different approaches that has been offered in TOP, but still want to optimize it more to see how we can attach them to treatment more. And in terms of medications, our idea is we want to identify their current medications and is it necessary to optimize the medications or even changing the approach. It's not necessary with medication, however, whatever that can optimize their management plan. So what we try to measure is monitoring changes to ONOS scores across time. This is one that basically is used for all of the clients at the beginning and it's been checked every several months. And try to see if we are successful with top projects, how we can compare these successful clients with previous successful stories that we had with ACT clients to see if there's anything shared, anything in common or anything in different, how we can use all of them together to improve the management plan. And we should still say that we have lots of, ACT clients have lots of barriers and issues that make it difficult to ask them to engage in this top care. I mean, the clients, for example, lack of housing, lack of social support, lack of appropriate communication means with them. So that are some of the barriers that we have during this project. Next slide, please. So within 1 week of meeting with top leadership, we have been able to identify appropriate clients which are matched or fit for this top collaborative. And we have been able to meet twice within the last 2 weeks, despite having very busy schedule. We start minute takings and ACT2 representative joined us as well. And lessons learned, we put meetings in calendar and use reminder emails in order to just, keep it smooth and moving forward. And what's the next step? We will continue our every other week meetings, regardless of the staff availability. We do our best to make it happen and continue to, recruit more representatives from all of the ACT teams. We try one at least per ACT team, but if we have more representative, that would be very ideal and appropriate and helpful. Next one, please. So ACT team, assertive community treatment. The point of contact would be Charmin, who is a team lead for this project, and you can see her email and phone number. Thank you.
Thank you so much, Talia, for sharing an update from your team. I'm going to move us along now. The next team to share is the West End Mental Health team, or West End Mental Health team.
Thank you. So at the West End Mental Health team, we have our top committee are Dr. Edwin Chete and Dr. Craig Haddon. Our case managers, Nina, Chris, and Nav. And new to our team, because newish to the role, our CRN, Rochelle Coleman. Myself, Sarah Johnson, and manager Susan Rochelle. And at the West End Mental Health team, we provide adult mental health services out of 3 bridges to the downtown south community. The next slide. So in the context for our team, like a lot of our psych nurses come from acute, and our physicians have experience starting clozapine in hospital and following clozapine treatment in community. We haven't yet started any clients in our top population of focus on clozapine. We have identified 5 clients who have treatment-resistant psychosis and who are being optimized on antipsychotic medications. One of the clients has been offered clozapine and has declined at this point, but we are working through patient education materials and just discussing the option with that client. Our aim by January 1st, 2022, we hoped that 100% of eligible clients with treatment-resistant psychosis will be identified from the client of interest list. And I feel like we have maintained a steady number around 5. And by April 1st, 2022, we're hoping that 90% of clients who are eligible for a clozapine start in the community and who accept the treatment will undergo titration in the community. So we'll see where that goes in the coming months. And 45% of clients undergoing clozapine treatment will see an improvement in their functioning as assessed by HANOS and the PANSYS SV. Next slide. We just used the drivers outlined through TOP. So integrating evidence-based guidelines into daily practice. And I believe our TOP team, the clinicians, are becoming more familiarized with clozapine procedure and kind of clinical practice as it relates to community practice. So that's been something that we've received benefit through. Secondary drivers, prescriber and clinical team knowledge of treatment optimization of psychosis increases. I think the knowledge has increased. We just haven't had the opportunity to start any clients as of yet. All the participation we've done so far in TOP activities, like we certainly encourage all the TOP team members to participate in all the education that's been offered so far. And we're meeting on a regular interval once a month to come together and check in around how our population of focus is doing and, you know, any areas for learning. Changes. We identified our population of focus. We used HANOS and regular caseload review between the case managers involved and our psychiatrists. We hadn't delegated a team lead, but we have done since recognizing that it would be important, and it's kind of helped with organization and just coordinating activities around TOP. We have regular meetings every 4 weeks, and I've really appreciated everyone's participation and commitment to meeting as a TOP for our TOP collaborative at West End. We developed a tracking sheet that kind of helped just see all the different activities associated with the clients in our population of focus. So that has kind of helped just notice like where things are moving. And I think for a while we were struggling with stagnation and, you know, what are we, you know, things don't feel like they're progressing, we're feeling things are sluggish, but being able to see, okay, we are actually having conversations with clients, like we're still in optimization of certain antipsychotics, we haven't moved past that, but things are happening. So it's been helpful to kind of see that and keep track. And staff have reviewed, like Nav joined the TOP team most recently and is reviewing all the TOP materials, and we're just making sure that we create space and opportunities for that. Next slide. So next steps, continue to meet regularly, use the tracking sheet, continue to have ongoing conversations with eligible clients about clozapine. And I have our tracking sheet on the next slide. Lessons learned, it's helpful to identify areas for learning and QI work as a team and engage with our TOP coordinator. We're happy to have Darwin, who's able to attend our next TOP meeting, just for some more guidance and ideas about how we can explore different QI initiatives at West End with regards to TOP. I like the idea of surveying staff that Kamloops had, just to take a pulse of our entire staff team and see where they feel like they stand with knowledge about clozapine or having experience starting clients on clozapine in hospital when they worked in acute, and then following up clients who are on clozapine and are in community and attached to our team. Yeah, I think we're just looking forward to kind of exploring different QI ideas like at our team, because I feel like we are moving as far as we can with our population of focus and where they're at. Next slide. So this is our tracking sheet template that we developed. So we have the client case manager and psychiatrist actually on the one that we use. It's not there. And then we just kind of go through all the updates per client, like for each month. And then we can, when the table's all filled out, you can see kind of where things have moved and where they haven't moved with each client. Next slide. Our team contacts, you can reach us at the mental health team number, or everybody's email is there. Thank you so much.
Thank you, Sarah and West End team. Up next, we have the Grandview Woodlands mental health team. Top trio.
Hello, everybody. Good afternoon. So I'd like to introduce our top team from the Grandview Woodlands Mental Health. We're the top trio. It's just the three of us. So it's Dr. Carolina Vidal and Dr. Jacqueline Matzik, and I'm the top project lead and a psychiatric nurse case manager. So our mental health team is located at the Robert and Lily Lee Community Health Center at the corner of Broadway and Commercial. We're a multidisciplinary team that serve adults 19 plus living with moderate to severe mental health, substance use, and concurrent disorders in an urban setting. Next slide. So briefly reviewing our context, our team recognizes the importance of keeping clients safe, healthy, and psychiatrically stable in the community. And this project has allowed us to reevaluate our priorities. And we recognize that there are significant room for growth when it comes to optimizing treatment through a variety of measures, such as adding, removing medication, reviewing side effects from current medication, and treating clients identified as treatment-resistant schizophrenia. So we either do clozapine, depots, or other alternative therapies. Reviewing our baseline, I've made some changes from our last presentation. A large percentage of our clients are actually quite stable due to good medication management, long-standing case management, and intensive psychosocial rehab opportunities. We have like a full-time rehab team with our rec therapists and OT, and we have a lot of programs for our clients. I've altered the baseline to reflect the current project population of focus. As you can see, we've identified 29 clients as significant TRS clients with a high HONOS and high complexity score. But I am confident there are more clients that would fall under this category if, say, their HONOS was updated or if their mental health status had changed. On a positive note, reviewing our team stats, we're right on track. About 50% of the clients identified are already on clozapine and 33% are on a depot, which gives us room for growth for about 17% of these clients, which are eligible for a clozapine trial. So for those recognized in these categories, one of our future PDSA cycles is to review all of these clients' HONOS scores and PANS and see if their clozapine or injectable doses could be titrated to optimize their dose in order for us to see any possible changes with their scores and to see if we can reduce further their psychotic symptoms. Next slide. So we aim to prioritize the opportunities given to us to optimize treatment for clients living with psychosis by providing our team with the capacity and resources to initiate clozapine and other strategies in the community. This will allow for clients to obtain a higher quality of life through decreased symptoms, reduced hospital visits and readmissions, increased ability to function at a higher level, and give them the ability to participate in our PSR activities. Next slide. So the goals have been the same, but we plan to reevaluate and change some of them as improvement goals for this year. So one goal listed this year is by May of 2022, we hope that our client that we started on clozapine will continue on this medication, as well as see signs of improvement in their HONOS or PANS score, as well as continue a safe titration in the community. Next slide. So these next two slides showcase one of our PDSA cycles that reflect how we were able to meet our December 2021 goal of finding clients for our population of focus and choosing clients from that list to start clozapine. So as you can see in our first PDSA cycle, if you start with what we plan to do, our plan was to identify and offer clozapine to 100% of clients from the POF who identify as treatment-resistant schizophrenia and are eligible for clozapine trial. So we were given the list, the client list of interest or client of interest list. And we did remove any clients that didn't have a recent HONO score and a score of a low HONOS or low complexity. So we tried to keep it within the high HONOS and high complexity score as a main priority. So we had 29 clients that were identified as high HONOS and high complexity. And what we learned from minimizing this group of clients is that we still needed more condensed group. It was just too many still. We wanted to focus on a smaller amount of clients to start with. Remember, like we just need one, right? So I said, you know, we need to eliminate more of these clients that were not really eligible, or they weren't an active client, or maybe they're already on clozapine or a depot. So we need to target some clients that are eligible. So afterwards, we were unable to offer clozapine or alternative treatments in this PDSA cycle. We had to change it. So if you go to the next slide, this is our PDSA cycle one, but second trial now. So we reviewed the new client of interest list and eliminated clients that were discharged from the team who are already on clozapine or on a depot, identified as stable on oral medications, or identified as not a good fit for clozapine. So we asked like physicians, case managers, if the clients were eligible, even if they've never started or if they've tried it before, can they continue on clozapine? You know, it was a lot of like trial and error and asking around and discussion. And then we realized here that after eliminating this group of clients, we were able to identify 3 of them that were eligible for potential clozapine start. So this process kind of allowed for physicians to review the client's charts, offer initial discussions regarding clozapine. One client was able to start clozapine trial while he was in the hospital in a medical unit. He wasn't admitted for a psych consult. He was there for medical issues, but we were still able to start him in the hospital because that was like perfect opportunity. He had some medical conditions and he was able to be safely started. And then we continued the titration in the community in Venture. So we conclude that a condensed POF allowed us to move forward with the project and concentrate our efforts with few clients to start clozapine trial. So we just eliminated process elimination for this PDSA cycle, and it worked for us. Next slide. So instead of reviewing our drivers and changes, since most of that hasn't really changed, we wanted to share some reflections on how we thought about this project so far, what were some of our challenges and our favorite benefits and outcomes that we've gained so far. So there are no changes or no new PDSA cycles started at this time between December and January. They were difficult to start due to like holiday break, staffing, but however, we'd like to mention some progress regarding one of the clients that had initiated clozapine. So he was able to continue his titration in Venture. We would have done this in the community, but the client has significant medical challenges that would pose a risk if we continued his titration at home. So the client is currently on a dose of like, I think 125 milligrams, and this dose is set to increase, but at this time, the client has declined for the increase. So maybe in the future, we're gonna try to up the dose in the community and see if there's any safe alternatives to titrate him up. There's been little improvement due to the short time frame to let this medication show its efficacy. But however, he is less expressive with his delusions, and there are still strong psychotic symptoms and no changes to his HONUS or PAN score. One of our PDSA cycles, we hope, will focus on titrating this client on an optimum dose safely in the community or back into Venture. So 2 of our clients that are currently on clozapine but not listed on the POF have switched from generic to CSAN in order for them to receive point of care support with the Pronto machines from 2 local pharmacies. So I know people are saying that there were some challenges for starting clozapine and how can people maintain their lab work. One of our main focuses at our office is trying to focus on these clients currently on clozapine and how can we make it more accessible and feasible. So we have switched 2 clients to 2 local pharmacies, Naz's and Robbins, that offer the service. And this has made blood work easier for clients. And I'll discuss this in another slide. We're also able to meet more in the past 2 months on a bi-weekly schedule. So every other Tuesday, we were able to schedule an Outlook and meet as a team. And that was really fruitful of a discussion. So some of the challenges we faced were, of course, staffing fatigue and shortages during the pandemic and the holiday season. Some clients would benefit also from a clozapine start in venture, but right now venture is totally overloaded, as you're all, whoever are in the Lower Mainland, are aware that they're holding a lot of clients there for, because of CTT housing shortages. So everything's back. Everything's like forced in the back. So right now we are waiting for some spaces to titrate some clients who are currently on clozapine to a safe dose, who aren't able to titrate in the community. And because of the new COVID strain, we had to decrease face-to-face interactions and less office visits. So this limited the time we had to use motivational interviewing techniques or have discussions about medication changes with our clients. And if we did have the opportunity to discuss medications, many clients were resistant with changing their meds, and we hope to use this opportunity, another PDSA cycle, to incorporate motivational interviewing techniques and enhance collaboration to talk about medication changes. But despite our challenges, we can see at the next slide our benefits and positive outcomes. So in the past year, this project has prompted physicians at our team to carefully review and optimize current clients' treatment plans. So they're more diligent with aimed tests, monitoring side effects, decreasing medications to reduce side effects, or increasing medications to improve any signs of psychosis or mood instabilities, and offer PSR support. So they're really good at not just using clozapine, but how can we optimize their current mental health and make it better? That's like improving their health and wellness. And we have also been focusing efforts to switch clients to pharmacies that offer point of care. So currently Wellness Pharmacy, which is Naz's, and Robbins Pharmacy offer point of care with a Pronto machine run by CSAN. So that gets sent directly, the lab information gets sent directly to CSAN, and clients are able to get their lab work done with a prick of their finger. So they can either go to the client's home or the client can go to the pharmacy. And it's been super helpful for those that have issues booking appointments to the lab or are unreliable with, meeting those appointment times. That's like weekly or monthly. So that's actually been really helpful. And we're still trying to transition clients to this process to make it easier, especially with those that are unreliable. And this project has prompted case managers to be mindful of their HONOS assessments. And additionally, it has allowed physicians, case managers, and clients to communicate more about their treatment care plans and collaborate on what medications would be suitable. Next slide. And finally, the next step, we are continuing to meet bi-weekly, and we hope to continue to optimize medications with clients through either reduction or adding of medications, either through depots, clozapine, or other antipsychotic medications. We want to find and incorporate family members still. We still haven't been able to do this just because of COVID and finding someone that's wanting to participate in the project. And then we want to have physicians to identify clients eligible for clozapine that are outside the population of focus on the list. And then we want to plan on doing some group education with all of our staff regarding the top tools that we've learned so far. And then we want to continue titrating our clozapine client to an optimal dose safely in the community. Next slide. So I always like to finish my presentations really cheesy with something, a smart quote. And I like this Albert Einstein quote: learn from yesterday, live for today, hope for tomorrow. The important thing is not to stop questioning. Talking about PDSAs and cycles and all this research, as long as we continue to not stop questioning ourselves and to make strides and changes, I think that this project's really helpful. And it's just the beginning. It's really a big umbrella that opens up opportunities for us to, not stop finding improvements in our delivery for clients. Anyways, thank you.
Thanks so much, Erica. That was a great presentation. And I like that quote you shared at the end. I would agree with that as well. So next up, we have the Kitsilano mental health team. We have someone that's going to speak on behalf of the team.
Hi, yes, this is me, Jenny Lynn. So we don't have a presentation, but I will give a brief update for the KITS team. So, one second. So hi, I'm Jenny Lynn. I'm from the KITS mental health top team. We are an adult mental health team servicing Kitsilano, Kerrisdale area in Vancouver. Since the last meeting, our team has expanded. We have recruited one new clinician and are currently in the works of getting another physician to join our KITS top team. We were able to utilize the resources on the top collaborative website, some of the recorded education, and then one-to-one meetings with Philip and Jessica from the core top team to bring them up to speed. Currently, our team has worked on 3 PDSA cycles, but we've had challenges with finding clients within our own top team caseloads and individuals within the client of interest list, and now have expanded to clients on other team members' caseloads. We were able to identify 4 potential clients who may benefit from treatment optimization for psychosis. Our next steps is to utilize the screen and management tool in our workflow, ensure HONOS is up to date for clients, and provide psychoeducation on long-acting injections and clozapine. Some of the barriers we have identified to treatment optimization include substance use in early remission, housing instability, and then concurrent complex medical needs. From a team perspective, there were challenges in finding dedicated time for the work. We have been utilizing casuals to help support with day-to-day workload so clinicians can focus on top work. We have been meeting as a team every 2 weeks to review our PDSA cycles and keeping it on our shared team drive. I think collectively as a team, we value using the PDSA cycles because it keeps us accountable. And it helps identify what tasks need to be done by who, what is working, what the challenges are, and what supports we need in place to support the work that we are currently doing. Yeah, I don't know if Ali or Dr. Angela Wong want to add anything, but that is kind of the brief update for our team.
Thanks, Jenny Lynn.